Hello to everyone. I am Jessica Goldstein, Education Program Coordinator at ASRM. Welcome to this webinar on ovarian reserve testing. Please join me in welcoming my colleague Jeffrey Hayes and today's moderator, Dr. Ann Steiner. Dr. Steiner is Professor and Chief Division of Reproductive Endocrinology and Infertility at Duke University. She has a research focus on reproductive aging, anti-Müllerian hormone, and predictors of fertility and infertility. She completed Time to Conceive, a prospective time to pregnancy cohort study, which evaluated whether markers of ovarian reserve are adequate predictors of current reproductive potential. Before we begin, please note, the webinar was developed by the American Society for Reproductive Medicine and the Society for Reproductive Endocrinology and Infertility as an educational resource in its service to members and other reproductive professionals. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website within the coming weeks. Please watch your email for notification. I will now turn the presentation over to Dr. Steiner to introduce today's speakers.
Today, I'll be talking about, we'll be focusing on utilization of markers of ovarian reserve in women without infertility. I'm pleased to have Dr. Erica Marsh and Dr. Irene Sue, who will be also presenting today. To start, I'll be talking about utilization of markers of ovarian reserve in women without infertility. I have no relevant disclosures. As women age, there is a decline in the number of follicles and oocytes. This results in a decline in the production of both AMH and inhibin. Lower inhibin B levels leads to an early rise in FSH, early follicular development, and elevated early follicular phase FSH and/or estradiol levels. Carl Hansen and his team showed us that AMH values are in fact correlated with AMH levels. They recruited 42 women aged 26 to 52 years of age undergoing oophorectomy for benign indications. Prior to surgery, they measured their AMH value. The ovary was subsequently dissected and the number of primordial follicles determined. Here we show that AMH and primordial follicle number were highly correlated. However, it is interesting to note that there is significant variation in follicle number in women with low AMH values. This may be due, in fact, to the fact that AMH is more adequately describes the functional ovarian reserve. AMH is produced not by the primordial follicle pool, but instead by the primary, secondary, and small antral follicles. In fact, AMH suppresses activation of the primordial follicles, that is, the initial recruitment from the primordial follicle pool to the growing cohort. Thus, AMH reflects the growing cohort that could be recruited for cyclic recruitment, but may not represent the overall number of remaining oocytes. However, in most women, the number in the growing cohort most likely reflects the size of the primordial follicle pool. Factors that therefore suppress the ovary by reducing ovarian stimulation may affect the functional reserve and lower AMH values. These include prolonged hormonal contraceptive use, depoleuveron, and hypogonadotropic hypogonadism. In addition, a number of studies have found that AMH levels tend to be lower in women with obesity, which a number of NICE studies recently have shown is not a dilutional effect. Since its discovery, there have been a number of research and now commercial assays developed to measure AMH. The first two commercial assays were the DSL assay, which was released in the US, and the Immunotech assay, which was exclusively marketed in Europe. Subsequently, the Gen 2 assay was released. It combined the antibody from the DSL assay and controls from the Immunotech. This new assay had issues with complement interference leading to imprecisions, although the assay protocol has since been adapted and the assay is much more accurate. More recently, the ANCH assay was released, which doesn't have this imprecision, and there are now 2 automated assays on the market that are FDA approved. It's important to know that there are different issues with each assay. There is quite a variation in how AMH is reported between the assays. They also use different units and use different cutoff values. So it's important to know which AMA assay you are using clinically. There have been a number of different age nomograms published for AMH. This is a nomogram published by Dolman et al. And JCAM. For any given age and AMH value, one can determine a woman's AMH percentile, or what I like to call her ovarian reserve for her age. For example, based on this graph, a 40-year-old female with an AMH of 1 is at approximately the 50th percentile for her age. Therefore, 49% of women have more ovarian reserve or more eggs remaining in their ovaries, and 49% have less. However, it is important to know once again which assay you are using, and it's best to select a nomogram which is based on the same assay that you are using in your clinic. Given that AMH does correlate with the size of the primordial follicle pool, it is not surprising that AMH values are associated with the probability of experiencing early menopause. In a nested case control study using the Nurses' Health Study, Bertrand Johnson et al. Were able to show that women with low AMH values had a significantly higher odds of early menopause, even after adjusting for age, race, smoking, and other factors. However, it should be noted that AMH values are a relatively poor predictor of an individual's woman age that she will actually go through menopause. An exception to this is the prediction of menopause, I should say normal menopause, not early menopause or premature ovarian insufficiency, using very sensitive assays that can detect AMH values down to the picogram per milliliter. In a recent analysis of women 42 to 63 years of age who were pre or perimenopausal at enrollment, the investigators in the SWAN study were able to show that women over 48 years of age with an AMH value less than 5 picograms per milliliter or 0.005 nanograms per milliliter had a 90% probability of reaching their final menstrual period in the next 3 years. In women between the ages of 42 and 48, an 80% chance of reaching their final menstrual period in the next 3 years. It was also reassuring to note that women with AMH values greater than 200 picograms per milliliter or 0.2 nanograms per milliliter had less than a 5% chance of reaching their final menstrual period in the next 2 years. However, despite being associated with age and menopause, AMH is not a predictor of a woman's current ability to conceive. This has been shown now in multiple studies. This data are data from the Time to Conceive study, which enrolled women between the ages of 30 and 44 years without a history of infertility who were trying to conceive naturally. Women were followed without an intervention until they conceived. This slide presents the Kaplan-Meier curves by levels of AMH, adjusting for age, BMI, race, prior pregnancy, and hormonal contraceptive use in the preceding year. Curves that are steeper have a shorter time to pregnancy, suggesting higher fecundity, and the flatter, longer time to pregnancy or lower fecundity. Low AMH is presented in this slide in yellow, normal in red, and high in purple. When you compare the women with low AMH to women with normal AMH values, there were no significant difference in time to pregnancy or fecundability, the probability of conceiving in a given menstrual cycle. Cumulative pregnancy rates after 6 and 12 cycle attempts for each level of AMH, low, normal, and high, are presented in this table. At 6 cycles of attempt, roughly 60% of all women in all groups had conceived. Cumulative pregnancy rates at 12 cycles of attempt were highest in the women with low AMH values and lowest in the women with high AMH levels. It should be noted, though, that confidence levels overlap. In summary, AMH can be used to measure a woman's functional ovarian reserve. Measuring AMH will help you to inform your patients as to how their ovarian reserve compares to other women their age. AMH is associated with age of menopause, but it should be noted that it's a relatively imprecise predictor of a woman's final menstrual period. An exception to this is for women in their late 40s with very low AMH levels as measured by highly sensitive assays. Finally, AMH is a poor predictor of reproductive potential and should not be used as a fertility test. I will be taking questions later on, but please do feel free to put questions in the question pool. Next, Dr. Sue will be speaking on the utility of ovarian reserve testing in the setting of fertility preservation. Dr. Sue is a reproductive endocrinologist and epidemiologist whose clinical and research focus is on the reproductive health of young adults with cancer. She is a professor in the Division of Reproductive Endocrinology and Infertility at the University of California, San Diego. Dr. Sue?
Hi, everyone. Thanks for listening in. So I thought we would talk about 3 objectives. First, I wanted to discuss the prognostic capability of ovarian reserve tests, which I will go forth and call ORT, at cancer diagnosis. I wanted us to recognize both the clinical and the research utility of ORT after cancer treatment. And finally, show you the little bit of data that we have and explore how gender-affirming hormone therapy, or GHT, impacts ovarian reserve measures in transgender males. So Dr. Steiner went through this already, but I thought that it would be helpful in the context of fertility preservation, again, to emphasize that while what we are interested in is the primordial pool on the left, which is the remaining supply of oocytes that we have, really AMH comes from the granulosa cells, primarily of primary and secondary follicles. Antral follicles are observed on ultrasound when you see the fluid sacs here on the late secondary or antral follicles. And of course, FSH, in interacting with estradiol and inhibin from the ovaries, is in the really a back and forth of the gonadotropin-dependent follicles. And as such, AMH, antral follicle count, and FSH are measuring the functional ovarian reserve. I thought we would start off with talking about what we know about ORT and oocyte yield in women who have unproven fertility. And so 2 examples are patients undergoing PGT-M and oocyte donors. And you see very easily and repeatedly a positive correlation of AMH and AFC with oocyte yield in these populations. The second question is, once you see this positive correlation, how does it impact your practice? So it turns out that the utility of ORT-based dosing algorithms versus standard dose FSH of 150 units is really uncertain. So this is a nice Cochrane review that's now, I think, a couple of years old. And what you're seeing is whether if you use those ORT to then base dosing algorithms, and this is primarily actually in the infertility population, that neither approach is better. As you can see that on live birth and ongoing pregnancy rates, the odds ratio is 1 with clear coverage in the confidence interval in about 2,800 individuals who are pooled, and that grading of the evidence is moderate. On OHSS, both severe and moderate, you see signs that ORT-based algorithm may be protective, although not powered in this meta-analysis, and the grading is low. So the take-home is that ORT algorithms in infertile patients don't appear to impact the live birth or ongoing pregnancy, but may, with a better powered sets of studies, decrease the risk of OHSS. So understanding that's what the utility is in women who don't have a history of cancer, I would want to turn our attention to measuring ovarian reserve in females with cancer. So this is how I view the cancer care continuum. And so on top, you can see that a young woman is diagnosed with cancer. She then undergoes cancer treatment, but really spends the bulk of her life in post-treatment survivorship. As we've often talked about, that long-term survival of over 5 years is more than 80–85% for children and young adults who are diagnosed with cancer. So there are 2 times where ORT may be considered. The first is at diagnosis, and the second is post-treatment. So at diagnosis, I think that there are 2 reasons why ORT helps us. This is a study, actually one of a few, where specifically the antral follicle count and the AMH, as you see on the y-axis below, are related to the oocyte yield after controlled ovarian stimulation in females who are newly diagnosed with cancer. And so in this study of 72 newly diagnosed cancer patients who were on average age 31, regardless of whether it is a random or a follicular phase start, those women who had an antral follicle count of at least 15 had a more than fourfold higher chance to store more than 10 oocytes that were mature. And so this is consistent with fertility preservation in women with unproven fertility. The second place where measuring ovarian reserve may be helpful at diagnosis is that there's actually a nice amount of data that AMH at cancer diagnosis will predict long-term ovarian function. So what it predicts, where you are prior to cancer treatment, predicts the rate of recovery after cancer treatment. It helps you to estimate the timing of recovering ovarian function after cancer treatment, as well as showing or letting us sort of estimate what is a likelihood that 2 to 5 years post-treatment that individual will be amenorrheic or an ovarian failure. So this is a study that our group has conducted where we took a cohort of breast cancer survivors who were undergoing cyclophosphamide-based chemotherapy. And during chemotherapy, because of the acute insult on the functional ovarian reserve, these individuals commonly have secondary amenorrhea, and that makes sense because you're destroying the growing follicle pool. Then, in those who have remaining primordial follicles that start to grow, then ovarian reserve will begin to, they will begin to recover ovarian function and show menstrual cyclicity. So we and others have consistently found that there are several intrinsic factors to the patients that are related to residual function. One is, what is your ovarian reserve before treatment? So in this graph, what you're looking at is that if your AMH is greater than 0.7, you get a point. If your age is younger, age younger than 40, you get a second point in this index score. And interestingly, if your BMI is higher, you get a score. And so the higher the score, depicted here in yellow, you're more likely to recover ovarian function, the phenotype of menstrual, having recovery of menstrual pattern after amenorrhea quicker, as you'll see that the inflection is quicker in yellow, as opposed to those who have low scores, where overall, over really 3-4 years of follow-up, you have only a quarter who have recovered ovarian function. So at least in breast cancer survivors, several cohorts suggest that cut point of 0.5 to 0.7 nanogram per milliliter predicts a likelihood of amenorrhea at 2 to 5 years after diagnosis. This change in points, or the cut point, is of course partly due to the differences in study population, but partly due to the inter-assay variability that Dr. Steiner spoke to in the last set. More data are really needed in females of other cancer types, as these types of prospective cohort studies have focused primarily on breast cancer patients. So switching gears to what is the use of ORT after cancer treatment. Almost a decade ago, really sort of thought-provoking epidemiologists took large cohort data on ovarian aging and combined them and analyzed them to develop the stagings of reproductive aging criteria. So you all recognize this as STRAW plus 10. And in STRAW plus 10, going across the top gray bars, there are 3 broad phases: the reproductive phase, the menopausal transition phase, and the postmenopause phase. And then within each, there are these substages that are defined by menstrual pattern and, as you'll see lower, supportive criteria of FSH, AMH, and Inhibin-B. And most women progress through these stages in order. And stages are related to symptoms. You can estimate the duration of the menopausal transition, and they impact, especially during the menopausal transition, on both short and long-term metabolic, cardiovascular, and bone health outcomes. In cancer patients, we've used ovarian function to essentially describe what happens after cancer treatment. We also use menstrual pattern, yes, no, to describe whether someone is ovarian failure. But that process of aging has not been well described. And so current guidelines from cancer societies are you monitor ovarian function via menstrual pattern without using endocrine biomarkers unless a problem like hot flashes arises. And so we wanted to ask, are straw criteria applicable to this population? And so this is a cohort of approximately 340 young adult cancer survivors. So they were between ages 18 and 39 now, and they were diagnosed with cancer between ages 15 and 35. So AYA aged, reproductive age survivors of AYA cancers. And we found that AMH and FSH tests in post-treatment cancer survivors provided additive information to menstrual pattern alone. And I'll quickly go through, I think, a pretty dense table and hope you'll bear with me. So on the top of the table, you'll see this is a current guideline. You take a young cancer patient and you use how many menses she's had in the prior 12 months. And in our cohort, there were 187 who had more than 10 that were not variable in length. So we call them in the reproductive stage. Those who had a persistent more than 7-day difference, we called those people in the early menopausal transition. Those who had amenorrhea of over 60 days, but less than 365, we called those people in the late transition. And if you had no menses in the past 12 months, we called this postmenopause, consistent with straw criteria. But when you add in AMH and FSH levels, what you're seeing is that you can distinguish between the peak and the late reproductive stage. And so you'll see that there were 115 women with regular periods and AMH and FSH levels that are consistent. You can then suss out those people who have either a low AMH or a starting to rise FSH into the late reproductive stage. And there's one unclassifiable patient who had lots of periods, but really low AMH and really high FSH. What got really confusing is when you get to the menopausal transition, you had a lot of unclassifiable participants. And those were mostly women who had menstrual pattern consistent with the menopausal transition, or over on the right, consistent with postmenopause, but ovarian reserve measures that were more consistent with the reproductive stage. So that overall, 29% of this cohort was unclassifiable by the current straw criteria. So our conclusions of this first study is that without endocrine markers, using bleeding pattern alone likely upstages these AYA cancer survivors' stage of reproductive aging. Also wanted to estimate how much of a window of ovarian function there is remaining after cancer treatment. So in a cohort of about 760 AYA cancer survivors, we asked these survivors to poke their fingers at home to give us dry blood spots in which we measured AMH. These survivors could be on the left right after cancer treatment or on the right all the way 20 to 25 years out. And if you measure AMH levels serially for about 18 months in each survivor and overlap their trajectories, you get an idea of what that recovery of ovarian function, how long they plateau for before they fall again, nicely without following a group of 700 women from cancer diagnosis for the next 25 years of their life. So using functional principle components analysis, we show that mean AMH level initially rises and looks like peaks around 3-4 years post-cancer diagnosis. And for that duration of plateau looks like it's up to 10 to 15 years later prior to decline. So after cancer treatments, we think that AMH levels reflect ovarian recovery, a prolonged plateau followed by decline. But importantly, unlike in the general population, in women without cancer, these AMH markers really fluctuate over time, that there is a rise before there is a decline. On the research side, I think it's interesting that AMH trajectories vary by cancer treatment toxicity. And so using known low, moderate, and high risk stratification by cancer treatment, what you'll see is that those with low treatment toxicity exposures, for example, methotrexate, are really in the green, that their curves are much higher than those who are high, for example, those who have transplant. We think that that uptick of the red toward the 10 to 15 year mark is really from a small sample size. The other interesting sort of note here is that the individual trajectories, which are the lighter crosses and lines that you see in the back, actually have a lot of overlap by color, even though the average trajectories differ by toxicity. So we probably haven't done enough work to suss out the cancer treatment toxicity of specific treatment regimens. So AMH and ORT, we think, measure that gonatotoxicity of cancer treatments. And moving forward, the research application with hopefully someday clinical yield is that maybe these ovarian reserve markers are a good way of measuring the toxicity of new drugs, because tracking menstrual pattern prospectively from cancer survivors are data that are really hard to get. And finally, I wanted to spend a couple of minutes talking about measuring ovarian reserve in transgender males. So the Endocrine Society guidelines are that we are to dose testosterone dosing such that serum testosterone is in pretty wide range, 320 to 1,000 nanograms per deciliter. And so cross-sectional data suggests that antral follicle counts may be higher, AMH levels would be lower. There are much more data on pathology specimens where transgender men who have been on T therapy have often polycystic ovarian morphology and more atretic follicles. So here is a prospective cohort study of hormone concentrations before and after T treatment, actually a combination of T and aromatase inhibitor. And what you'll see is that AMH levels in these 22 individuals prior to treatment at that median of 3.5 looks higher than post-treatment at 1.4. However, these studies are tricky because oftentimes there are multiple drugs in the regimen, so including GnRH agonists for pubertal suppression, which we know also suppresses AMH, progestins for menstrual control, and AIs to decrease estradiol production. To date, there are really no good prospective studies evaluating the long-term effects of hormone therapy on fertility, although there are a few reports in the literature of transgender men who have carried pregnancies and given birth. In individuals without DOR, there's a really small cohort comparing transgender men on and without hormone therapy, in that if they don't have DOR to begin with, the antral follicle count and oocyte yield was similar between those who are on hormone therapy versus none. So this is showing you the co-administration of multiple drugs that could affect ORT. So I think currently where we are is that short and long-term impact of T and other GAHT on ORT and fertility remains unknown. So my take-home points are that AMH, FSH, and antral follicle count measure the functional ovarian reserve. So accordingly, they help us to predict the response to COS, but they don't predict oocyte quality. In cancer survivors, AMH at diagnosis predicts long-term ovarian function. It's also a measurement of treatment gonatotoxicity. Finally, due to multi-drug regimens and a lack of prospective cohort studies, the short and long-term impact of T and GAHT on ovarian reserve testing and fertility is unknown. These are my acknowledgements and how we do lab meetings in San Diego, and the work presented are of the trainees here on the left. Happy to answer questions. Thank you so much.
Next, we'll be hearing from Dr. Marsh, who will be speaking on ovarian reserve testing. Do ancestry, ethnicity, or race matter? Dr. Erica Marsh is the S. Jan Behrman Collegiate Professor of Reproductive Medicine at the University of Michigan Medical School and Chief of the Division of Reproductive Endocrinology and Infertility in the Department of OBGYN. Dr. Marsh's research interest is in comparative reproductive health and health disparities across populations. Dr. Marsh?
Thanks for that kind introduction, Dr. Steiner, and thank you to ASRM for the opportunity to be a part of this panel. I have no relevant disclosures. By the end of this presentation, I'm hoping that you will be able to, 1, differentiate between ancestry, ethnicity, and race. 2, describe the differences seen in FSH, AMH, and antral follicle count across groups based on the available data. And 3, define allostatic load and understand how racism impacts health. The question we were charged to discuss is, do ancestry, ethnicity, or race matter? And just to cut to the chase, the answer is that the clinical role of ancestry, ethnicity, or race remains unclear because it's understudied. One of the reasons for this lack of clarity is the use of these three words as if they were the same when they're not. Ancestry is the most straightforward and objective of these and refers simply to the line of descent. Ethnicity is derived from the Greek words ethnos and ethnikos and loosely translates into folk or people and refers to a category of people who identify with each other, usually on the basis of similarities such as common language, ancestry, history, society, culture, nation, religion, race, or social treatment. Thus, there is an element of choice in ethnicity, and there is overlap with ancestry. And lastly, race is based on shared physical or sometimes social qualities into categories generally viewed, as distinct groups. It's largely based on physical characteristics like skin color, eye shape, height. Race also overlaps but is distinct from ancestry, and the view of race as a purely social construct is relatively new. So why would race matter in ovarian reserve? There's several epidemiological observations that suggest a difference. For example, differential age of menarche. While the median age of menarche is about 12.4 years, we know that the age at menarche for non-Hispanic Black girls is significantly earlier than that of white girls at the 10th, 25th, and 50th percentile of those who have spontaneous menarche. Data on the age of menopause also has been shown to be different across race and ethnicity, with age at menopause either being reported as similar between Blacks and whites, or in some studies 6 months earlier in Black women, and with Latinas and Native Hawaiians experiencing menopause earlier than white women, and Japanese women of Japanese descent entering menopause later than whites. There's differences observed in dizygotic twinning rates. Martin Bulmer's classic paper in 1970, The Biology of Twinning in Man, identified the significant difference in dizygotic twinning rates ranging between 2% amongst people in sub-Saharan Africa to 0.5% in Asia, with Europe resting somewhere in between. And lastly, there's some IVF data that suggests that ovarian reserve may be different across races amongst couples with infertility. The bottom line is that inclusion matters and representation matters in terms of answering that question. And so to get at the bottom of some of those differences, let's start to talk about what we know. So in terms of FSH, there are not many data across racial and ethnic groups, particularly that focus on early follicular phase FSH. Driven by questions regarding racial differences in FSH, we looked at age, BMI, and cycle length matched cohorts of Black and white women. We confirmed that they had similar follicular phase length, luteal phase length, polycystic ovarian morphology, and similar dominant follicle size. We had each of the participants in this study draw her blood each day throughout an entire menstrual cycle. And when we looked at the estradiol levels across the cycle, we saw higher levels in the African American cohort than the Caucasian cohort of women, with the African American cohort being seen here on the left and the Caucasian cohort being seen here on the right. Summary data of both cohorts is shown here and shows specifically the increased rate of or increased levels of estradiols of African American women who are represented in Black circles versus white women who are represented in the lines with white circles in the mid to late luteal phase as well as the late follicular phase. When we looked at all sex steroid hormones and gonadotropins across the menstrual cycle, much to our surprise, we found no differences in FSH between the two groups. In terms of AMH now, there are more studies available. Bleal and Cedars and their team looked at AMH in a cross-sectional study of the OVA cohort of about 950 age-matched women across 4 racial and ethnic groups. All were healthy and regularly cycling women and had used no hormonal medications within the last 3 months or hormonal affecting medications within the last 3 months. This study found that compared to white participants, African American, Latinx, and Chinese participants had lower AMH levels until age 40, when African American participants tended to have the highest AMH levels through age 40. So here we see the means at each of these 5-year increments, with white women having the highest AMH at 25, 30, and 35, and then African American women having the higher AMH levels at 40 and 45. And that same observation is shown here graphically, with white women being the top line and Black women being seen here being lower initially and then having the higher AMH levels at age 40 plus. So that study showed racial and ethnic differences in AMH in a regularly cycling cohort of women. When we turn to infertile populations, these differences aren't seen consistently. In 2016, Ulcha, Scott et al. Published work on a cohort of about 2,500 infertile patients who had undergone genotypically determined ancestry. After controlling for age and BMI, there were no differences seen in AMH, antral follicle count, or oocyte yield. There were, however, slight differences seen in FSH levels between patients of Central and South Asian ancestry versus European ancestry, and that's shown here. But those differences were not felt to be significant and were 6.46 versus 6.97. So basically, no differences seen in an infertile population in AMH, AFC, or oocyte yield by ancestry, but mild differences seen in FSH between Asian women and white women of unclear clinical significance. Focusing on what's called ethnicity in this paper, and again looking at a population of infertile women, Iglesia and Garcia Velasco et al. Looked at 465 Spanish and Indian women. These women were self-identified, undergoing IVF, and found that while Indian women had better AMHs and FSHs, AFC in Indian women was similar to that of Spanish women who were 6.3 years older. So refocusing exclusively on AMH and specifically in the African American women, the NIEHS self cohort, so the study of environment, lifestyle, and fibroids cohort, which consists of about 1,654 reproductive age African American women, was assessed for anti-Müllerian hormone. This was an unselected group of women who were healthy and between the ages of 23 and 34 at the time of recruitment. AMH was assayed on each of these participants at their baseline visit, and cross-sectional analysis was done. And we found that in this large cohort of African American women, obesity, whose data are largely show a negative impact on AMH, was shown to clearly have an impact in this cohort, as well as current hormonal contraception use and thyroid condition were all associated with lower AMH levels, while at reports of abnormal uterine bleeding and cycle length greater than 35 days were associated with higher AMH levels in this cohort. When we look at this cohort and do a deeper dive into obesity, as well as use of alcohol and cigarette smoking, we find that BMI, leptin, and adiponectin ratio were associated with lower AMH levels, as was binge drinking. There was no association seen between tobacco use of any kind any amount or any concentration that had an impact on AMH levels in this cohort. So 2020 has brought 400 years of racism and oppression to the forefront of this country, and has also forced us to look at the impact not only of race, but more appropriately of racism on health, and to understand how it manifests. We know it when we see it, but we have to look and see it. So racism's hidden toll. One of the ways that racism is hypothesized to impact health is via two mechanisms. Next, one is social determinants of health, which are amplified by racism and are caused by racism, as well as increased allostatic load, which is a downstream effect of the chronic stress seen and experienced by people who suffer from racism. In terms of social determinants of health, most of us have heard of the term, but specifically, they refer to conditions in which people are born, grow, live, work, and age. The social determinants of health include factors like socioeconomic status, education, neighborhood, and physical environment, as well as employment and social support networks and access to healthcare, as shown here. Using a subset of participants from their OVA study, Lill and Cedars published this thought-provoking and creative piece entitled, "Is in utero exposure to maternal socioeconomic disadvantage related to offspring ovarian reserve in adulthood?" So essentially asking the questions, do social determinants of health experienced by the mother of OVA participants have an impact on the ovarian reserve of the participants themselves? To determine socioeconomic disadvantage, they used addresses from participants' birth certificates, geocoded them, and linked them to US Census-derived variables, including poverty levels, unemployment rates, and education levels. Using covariate adjusted linear regression models, they found that greater maternal neighborhood education was associated with higher AMH and AFC, while higher maternal neighborhood poverty rates were associated with low AMH. An allostatic load, the endpoint, refers to physiological response, again, to the chronic exposure to fluctuating or heightened neural or neuroendocrine responses resulting from repeated or chronic stressful events. We all experience allostatic load, but there are racial differences in the impact and the amount of allostatic load between, as shown here, between white women and Black women. One of the challenges with allostatic load is that there's not a gold standard of how it's measured, but common markers for allostatic load include combinations of the list you see here. There haven't been any studies that looked at allostatic load specifically on the markers of ovarian reserve, but there is one study that looked at load on differences in obstetrical outcomes as well as fertility outcomes. Allostatic load impact on obstetrical outcomes is well established and is shown here in this table. When they looked at fertility outcomes, and this is one of the first, if not the first paper that's looked at fertility outcomes related to allostatic load, no differences were found. However, that paper did not look specifically at ovarian reserve markers. So what do we know? There's no difference in there doesn't appear to be a difference in early follicular phase FSH levels, despite higher estradiol levels in African American women compared to Caucasian women. AMH levels are lower in African American women compared to Caucasian women, but experience less of a reduction in AMH with advancing age. And those of Latinx and Chinese women, the AMH, of Latinx and Chinese women may be lower compared to white women in general. There have been mixed outcomes on racial and ancestral differences in antral follicle count, and most, not all, but most of these studies have been done in infertile populations. We've found pretty consistently that increased BMI, current hormonal contraception use, and binge drinking are associated with lower AMH levels in African American women, where abnormal uterine bleeding and cycle length greater than 35 days were associated with higher AMH levels. And lastly, there's very limited work on looking at the impact of racism on ovarian reserve markers, specifically that are focused on social determinants of health and the allostatic load, and that's a space where we do need more research. When we go back to our question of does ovarian testing matter, again, the clinical role is understudied, it remains unclear, and there's a lot of variation between the populations assessed, how race, ancestry, and ethnicity are defined, in which markers of ovarian reserve are being used. But I would say these factors always matter. I want to acknowledge my current research team, division, collaborators on much of the work that was shared with you today, and funding. And I'm happy to take questions now along with the other panel members. Thank you.
Dr. Steiner will moderate this session.
All right, so please welcome additional questions. I'd first like to just thank our speakers for their excellent presentations. I learned a lot today. I thought I'd start by saying there was a question put forward about what additional research or data would help. I'll ask each one of you to think for one moment and 1 second to come up with one additional research question you think or data we need. If you could choose just one. I'll take a stab at the first one. How about, I almost cut off Dr. Sue there, sorry. But I'll take a stab and give you a second there. But I would say, while we know that AMH is not a marker of a person's current reproductive potential, I think we're all stuck in this situation where somebody comes in, is not trying to conceive currently, but wants to know about their future fertility. So then they're in your office with their marker of ovarian reserve at 34, wanting to know based on that marker what is going to be their chances to conceive at age 40. And unfortunately, I don't think we have an answer to that. And I'd love to see kind of more information or an answer to that question. Do these fertility tests predict my future fertility, which is a lot of what I think women are asking when they're getting their fertility testing done. So that's my research question I'd like to know. Dr. Sue?
I have so many. But
I know, you've got to choose just one.
Okay. On the forefront of my mind remains, because I think that ovarian reserve tests can help these populations of young cancer survivors potentially know how much ovarian function, or really how is a surrogate for how much ovarian reserve really is remaining, and that has impact on menopause and other things outside of fertility. I really would like a better way of measuring both treatments and longitudinally what happens to those ovarian reserve measures. So being more specific than where we currently are, how much cyclophosphamide equivalent dose have you got, and that's not specific enough.
Great. Dr. Marsh?
I would like to see normative data of ovarian reserve markers across populations of women that have not are relatively understudied in the population, because I think before we can start asking questions about infertility or even age of menopause, if the lens that we use is a population of Scandinavian women, then we don't know that that's applicable. So I think normative data isn't normative at all if you're not included in it. So my research or my research proposal would be to do a large-scale longitudinal study of multiple ovarian markers in an unselected population that would include normally cycling, not normally cycling, infertile, fertile women, so that we can actually get normative data and then start asking that next level of question, which is, well, what happens in infertility? Thanks, Dr. Steiner.
Okay, So, so I think I'm going to go on to a couple of other questions here. So the next question was, is there an international standard to standardize AMH assays as there are for gonadotropin assays? As far as I'm aware, there is not a current standard, unfortunately. We don't even have standard controls along those lines. So I'm not familiar with one. It certainly would be nice to have a standard controls that could be used so that we could somehow compare these assays. But I don't think we're there now. Dr. Sue, Dr. Marsh, are you nodding? You agree with me?
Right, I agree. And it's, you know how you can do those like passing Blaylock curves to see one assay versus another, how far off are you? It's not linear. It's not like you can translate 0.2 of the Roche assay equals 0.3 of the ANCH assay. It's not. So that's why when you make your trainees come back to look at the primary literature, the application is to the assay that it was measured in.
I think we learned that unfortunately learned that, Dr. Sue, in trying to combine assays, right, in the past.
I think that's even more important now that they're automated assays. When all of the assays were manual, there were still differences, but I think it was easy. There was less of a pull to stray from the assay that you had started with. Now that they're automated assays, which are much less expensive, and there's going to be, and can be that allow quicker assessment of samples and more standardized, presumably, assessment of samples on a large scale. For those of us in this research space, we want to be able to consider potentially jumping over to an automated assay, and that's hard to do when there's not standardization. So
I'll go on to the next one. This asks, what testing do you recommend for use by OBGYNs who have patients that are interested in better understanding their fertility status because they are planning to put off pregnancy due to education or career or commitment? I'll be honest, a bad test is worse than no test. So I would say we actually have a test that's very good, and that is a woman's age. And we can do lots of counseling. We know lots about rates of decline in fertility based on a woman's age. So I, at this time point, do a lot of counseling about reproductive aging based on a woman's age, and really encourage people to steer clear of using AMH. And I'll follow that up because another person asked about if somebody is sent to me regarding with a low AMH for counseling regarding oocyte cryopreservation. I recommend also along the same lines using age as the primary decision maker or primary driver as to whether or not to freeze eggs, and of course their reproductive goals. If their plan is to start reproducing the next year, I think that's very different from planning for a number of years from then. But I combined two questions into one, but I'd like to know what the others, experts on ovarian reserve, how they counsel their patients who are considering delaying their attempts to conceive. Dr. Sue and Dr. Marsh?
Maybe I'll take a stab. I think that it's central that when you counsel patients, and I think that you see some of the backlash of fertility preservation in the general population, that you froze this many eggs for me and this didn't result in a baby, and it's in the Modern Love column of the New York Times. So I think counseling is central. So that means that for that person with low AMH in whom you then decided you're going to freeze eggs because she's not going to have, try to become pregnant for another 2 to 3 years, a low yield is concordant with her low AMH, but letting her know that that does not mean that she's infertile, right? And so I think that distinction has to be clear in your counseling and about expectations.
Dr. Marsh?
I think you two have nailed it. When I get similar request or a call from some of my generalist colleagues, I encourage them to not test for that very reason, because the test isn't able to answer the question that either the patient wants answered or the provider wants answered, and to do an age-based assessment.
Thank you. Thank you. Okay. Okay, sorry, I'm trying to get through some of these real quick. Okay, I think this is an interesting follow-up question to you, Dr. Marsh, is how do you counsel your patients about number of eggs to freeze? Do you factor in genetic risk, ethnic, and other factors when setting an egg freezing target?
I don't at this point. I don't factor in race and ethnicity. Let me say that at this point, or ancestry, because we don't have any normative data. So I do disclose that to the patient, that the recommendations that I'm making are largely recommendations that are based on cohorts in which they may not be represented. But that's the data that we have right now, and but I don't take into account or I don't differentially counsel based on race or ethnicity or ancestry in terms of egg freezing.
Dr. Sue, I wanted to know how often do you measure ovarian reserve tests in post-treatment cancer survivors?
So there are no clinical guidelines that tell you. As I said, the clinical guidelines are watch what happens to their periods, which is, I think, not adequate. So currently, clinically, we are measuring every 12 months or so that we can, because the people who are seeing us are the people who potentially want a second window of fertility preservation. So I'm looking for that plateau, and that's why I measured at 6 and 12.
And what about endocrine therapies? Do we need to be concerned about how these aromatase inhibitors that all these women are on are going to affect? Are they falsely lowering?
Yeah, so that's really interesting. So that tamoxifen data comes from like the 1970s and 1980s, when tamoxifen was just starting to be applied. And so if you are truly postmenopausal and on TAM because of the SERM effect, then FSH levels look lower than they otherwise would. But in people who are still having ovarian function underlying, then the FSH is kind of either all over the place or a little bit higher than what you would expect. On GnRH agonists, as you guys have said, and that's the most common setting that the AIs are being used in, then AMH is often suppressed.
Great, thank you. I'll have one last question that was placed in before we close it, and they were asking about whether or not there's a correlation in with low AMH and risk of poor oocyte quality and risk of miscarriage. I think those are two different questions. I think I will say that AMH is not a marker of oocyte quality. I feel pretty confident in that. Dr. Sue and Dr. Marsh, do you feel pretty similarly along those lines?
Yes.
I think what's interesting, the association between low AMH and risk of miscarriage has been interesting. There's no consistent finding. I'll say that in time to conceive, we found in women with very, very low AMH values an increased risk of miscarriage, but this has not been seen in other cohorts, and I should say it was a very unique group that they were very low AMH, and we have not seen, I don't think that this relates necessarily to oocyte quality. I think there may be other factors that contributed to those women miscarrying. So I think the relationship between very low AMH and miscarriage, there's a little bit more to be teased out there. I'd like to see more studies. I said some very large studies have not seen an association, but I think pretty strongly we all would conclude that AMH is not a marker of oocyte quality. So,
yes.
Anyway, okay. So I'd like to thank our wonderful speakers today, and for ASRM for giving us the opportunity to present and speak with everyone today. Thank you.
Thank you, guys.
Thank you.
Thank you.
Thank you to our panelists and attendees. You will receive an email survey after this session. Your feedback helps us give you the most relevant content, and your input is very much appreciated. This session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. And for any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.